Dull epigastric pain, often occurring after consuming spicy foods or during periods of high stress, is a common complaint. While frequently dismissed as minor indigestion, it can be a clinical sign of a significant underlying condition, the erosion of the gastric mucosa by endogenous acid. This overview will delineate the 5 key signs of gastritis, often overlooked by the general population, and outline a standard 14-day treatment protocol. This information is particularly relevant for individuals experiencing recurrent stomach pain. Case presentation. A typical patient profile involves an individual with a high-stress occupation and poor dietary habits, e.g., frequent consumption of instant noodles and coffee. Common presenting symptoms include persistent, dull epigastric pain, particularly on an empty stomach, hunger pain, postprandial bloating and abdominal distension, and frequent eructation, belching, with an unpleasant odor. Such symptoms are often misdiagnosed by the patient as simple dyspepsia. However, upon endoscopic evaluation, the gastric mucosa may reveal diffuse erythema and edema consistent with an inflammatory process. The definitive diagnosis in such cases is acute gastritis. It is critical to understand that if left untreated, chronic gastritis can lead to significant complications, including gastric ulcers, gastrointestinal bleeding, and most seriously, it is a known risk factor for the development of gastric cancer. Early identification and management are paramount. Clinical manifestations. The 5 key signs of gastritis. Epigastric pain, the rhythmic discomfort. This is the most classic symptom. The pain is typically localized to the epigastrium, the upper abdominal area below the sternum and above the umbilicus. It is characterized as a dull, burning sensation. A key diagnostic feature is its predictable rhythm. The pain is exacerbated by fasting, as gastric acid directly irritates the inflamed mucosa. Conversely, the pain is often alleviated post-meal, as food acts as a buffer. Bloating and abdominal distension. Impaired gastric motility. Inflammation of the stomach lining can impair gastric motility and delay gastric emptying. Food remains in the stomach for a longer duration, leading to fermentation and gas production. Consequently, patients report a persistent feeling of fullness and bloating even after consuming small amounts of food. This excess gas results in frequent eructation, belching. Anorexia and early satiety. Gastric protest. This is a direct consequence of impaired motility. With the stomach already distended with gas and retained food, stretch receptors signal to the brain a state of fullness. This leads to anorexia, a loss of appetite, and early satiety, where the patient feels full after eating only a small portion of a meal. Nausea and vomiting, a protective reflex. As the inflammatory condition worsens, the stomach may initiate a protective reflex to expel its contents. The presence of frequent nausea, particularly postprandial, is a significant warning sign. Halitosis, an unsuspected culprit. Halitosis, or bad breath, can be an overlooked symptom of gastritis. Delayed gastric emptying leads to the stagnation and fermentation of food, promoting bacterial overgrowth. These bacteria can produce volatile sulfur compounds, which can travel up the esophagus and be expelled orally, causing malodorous breath unrelated to oral hygiene. Etiology: the causes of gastritis. Group 1. Exogenous infectious agents. Helicobacter pylori, HPylori, the primary culprit. This spiral-shaped bacterium is responsible for over 80% of chronic gastritis cases. It uses its shape to burrow through the protective mucus layer of the stomach. It also secretes the enzyme urease, which neutralizes surrounding acid, allowing it to survive and colonize the gastric lining, thereby inducing a chronic inflammatory response. Group 2. Endogenous factors and substances. Overuse of NSAIDs, non-steroidal anti-inflammatory drugs. Medications such as ibuprofen, aspirin, and diclofenac are effective analgesics but can be detrimental to the stomach. They inhibit the synthesis of prostaglandins, which are crucial for stimulating mucus secretion and maintaining mucosal blood flow. The loss of this protective mechanism renders the gastric wall vulnerable to acid-induced injury. Alcohol and tobacco, the destructive duo. Alcohol directly irritates and erodes the gastric mucosa while simultaneously stimulating increased acid secretion. Tobacco, nicotine not only increases acid production but also reduces blood flow to the stomach, impairing the natural healing processes of the mucosa. Severe physiological stress. This refers not to daily occupational stress, but to severe physiological trauma such as major surgery, extensive burns, severe injuries, or sepsis. In these states, the body shunts blood flow to vital organs, the heart, brain, reducing perfusion to the stomach and compromising the integrity of the mucosal barrier. Group 3. Lifestyle factors. Irregular dietary habits. Skipping meals allows gastric acid to accumulate without a food buffer. Conversely, overeating can cause excessive stomach distension. Irritating foods. Regular consumption of excessively spicy, acidic, or fatty foods can increase the physiological load on the stomach and irritate a sensitive or already inflamed gastric mucosa. In summary, gastritis is typically multifactorial. A thorough understanding of the primary causative factors is the first step towards formulating a correct treatment plan. Management principles. Treatment must be directed at the underlying cause. For H. pylori infection, a combination antibiotic regimen is prescribed, typically a 14-day course. Strict adherence to the full regimen is crucial to ensure complete eradication and prevent antibiotic resistance. For lifestyle-induced gastritis, cessation of the offending agents, e.g. alcohol, tobacco, irritating foods, is required. Supportive medications. Proton pump inhibitors, PPIs. These drugs act by suppressing the gastric pumps, thereby reducing acid production and creating a favorable environment for mucosal healing. Mucosal protective agents. These agents form a physical barrier over the inflamed mucosa, shielding it from further acid damage. Conclusion. Gastritis is a serious inflammatory condition that, while treatable if detected and managed appropriately, can lead to severe long-term complications. Abdominal pain should never be dismissed. It is a critical warning signal from the body.